This conference will now be recorded.
Good morning. Am I audible? 53, Kirti? Am I audible, Kirti? Shalini, number 73?
Yes, ma'am. Yes, ma'am.
So today's topic is Down syndrome.
Ma'am, you're audible, ma'am.
So this is the most common and most best known chromosomal disorder in humans, and it is one of the most important cause of intellectual disability also. The frequency ranges from 1 in 800 children to 1 in 1000 children. So what is the primary cause? It is the trisomy of the chromosome 21. The problem is in the chromosome 21, which occurs as trisomy, which give rise to multiple systemic complications. And however, there is a wide range of phenotypic variation, which we'll discuss in the later slides, except that trisomy. The origin of extra chromosome will be either maternal or even paternal also, but most of the cases it is from the mother. So you can see the red mark one. This is the trisomy 21, where you can see 3 chromosomes. So it occurs more often in offsprings of mothers conceiving at older age. And see, if the mother age is 15 to 29 years until less than 30 years, so the risk is 1 in 50. As the mother age is increasing, the risk is almost half. See, if it is 32 to 34 years, 1 in 800. If it is 35 to 39 years, it is 1 in 270. If more than 45 years, it is 1 in 100. So this is why the age is playing an important role in the Down syndrome. Because as the age is increasing, the exposure of the oocyte, that is the exposure of oocyte to harmful environment influences for a longer period. So normally if the age is less, the exposure of oocyte to the harmful environment is less. As the mother age is growing on, the oocyte to the harmful environment, like repeated number of viral infections, repeated bacterial infections, at the age of 15 or in a teenage, they might not be having any other issues. But as the age grows, some comorbid conditions like chronic conditions might appear, like hypothyroidism in the mother, or any diabetes, mother having any hypertension. If more than 40 years, nowadays diabetes is common. And number of viral infections. As the infections are going on, the risk of oocyte to harmful environment is increasing. So this makes a role. So coming to the cytogenetics, the regular trisomy is seen in 94% of cases. This is the, already I've told you, difference in the phenotypics are present. So 94% of cases, it is the regular trisomy. And in 1% of cases, these are mosaic forms. So mosaic, you should write 3 forms: trisomy, mosaic, and translocation also. So trisomy 94%, 1% are mosaic forms, and rest 5% due to translocations, most commonly involving the chromosome 21 and 14. So some part of the chromosome of 14 will be translocated to the chromosome 21, or vice versa also can occur. So trisomy, mosaic, and translocations are seen. So what are the clinical features and diagnostic considerations? So the symptoms include easy fatigability of the child, but that is a vague symptom, and neck pain. Limited neck mobility is seen at torticollis in some children. Whenever a child comes to you with a complaint of torticollis, you should suspect Down syndrome and you should look the facial features. Difficulty in walking or change in the gait pattern. Any loss of motor skill. If the child is having loss of motor skill, that should poke you about Down syndrome. And incoordination or clumsiness. Motor skill, if lost, incoordination will be present, and clumsiness in every task given. Presence of any sensory deficits or presence of spasticity or hyperreflexia. If spasticity is there, tone is increased and hyperreflexia is common, and clonus, if hyperreflexia is there, tone is more, clonus will be present. And extensor plantar, any plantar extensor except in physiologic forms like sleeping children are less than 1 or 2 years, and change in the bladder or bowel functions, and change in the sensation and in hands and feet. All these symptoms you should suspect of Downs, and you should look for the facial features. These symptoms often remain relatively stable for even months to years. So they are stable for even months to years, and in rare cases, the symptoms may progress to paraplegia, even paraplegia, or hemiplegia, or quadriplegia, or death. So these are the symptoms. Most important are motor incoordination. Child has not evolved the developmental milestones, or motor milestones are less, or any clumsiness in task, and presence of any neck pain or torticollis, or change in walking or gait pattern, and increased tone symptoms like spasticity, hyperreflexia, clonus, and extensor plantar. All these you should suspect Down syndrome. So coming to the physical examination, these include characteristic craniofacial findings such as flat occiput and a flattened facial appearance. The child will have a flat occiput and small brachycephalic head, presence of epicanthal folds and flat nasal bridge, upward slanting of palpebral fissures, and brush field spots. These are the things you have to write when a 4-mark question is given for you. Flat occiput, absence of nasal bridge, flat nose, brachycephaly, epicanthal floats, upward slanting of palpebral fissures, and brush field spots. Small nose and mouth will be seen, and trunk will be protruded. Small and dysplastic ears are seen, and nuchal skin, generous nuchal skin will be seen in a case of Down syndrome. So this is a picture just depicting a Down syndrome. There will be upward slanting of palpebral fissures. Bilateral epicanthal folds are seen. There is a small flat nasal bridge with a small nose, small mouth, and tongue is protruded. So these are the palpebral fissures where you can see the upward slanting. So see, there will be low hairline and nuchal folds will be seen, and see the dysplastic ears. So general physical features may include the following. These are shortened extremities, short and broad hands may be present, with short fifth finger, with hypoplasia of the middle phalanx and clinodactyly, along with presence of single transverse palm arteries. There may be sandal gap and joint hyperextensibility. Sandal gap is the gap between the big toe and the second finger in the foot. So this is the picture showing the sandal gap. So hypertelorism, protrusion of the tongue, and single palmar crease. In this picture, you can see the single palmar crease present. and protrusion of the tongue, and hypothyroidism. You can see the increase of space between the imaginary line drawn between the pupils. Diastasis recti, presence of dry skin, premature aging, and wide range of IQs. The intellectual quotient have a wide range, and presence of congenital heart diseases are common in Down syndrome. So umbilical hernias are common because of the hypotonia present in Down syndrome, and diastasis recti will be present. So umbilical hernia is common. The chain, when comes to you with umbilical hernia, you have to rule out hypothyroidism also. Any hypotonia features are there, you have to rule out hypothyroidism. Dry skin and umbilical hernias are common in hypothyroidism also. Coming to the congenital heart diseases, about 40% of the children have congenital heart diseases. Endocardial cushion defects are more common, and these are seen in 40 to 60% of cases. Presence of congenital heart disease is most significant factor in determining the survival. All children should have a cardiac evaluation before 9 months of age. So any suspected of Down syndrome, you should take a 2D echo, even if there are no murmurs and there are no clinical features. You should go for a 2D echo. Gastrointestinal malformations. Atresias are present in around 12% of cases, especially duodenal atresia. There is increased risk of Hirschsprung disease. Eye problems increase the risk of cataract, nystagmus, squint, and abnormalities of visual acuity. The routine evaluation is done in the first year, and every year it is indicated in the every year. So at the presentation of congenital Down syndrome, you might not have been saying this sensorineural hearing defects or eye problems or GI malformations, but every year you have to screen them. And thyroid also you have to send it every 1 to 2 years. Hearing defects, 40% to 60% have conductive neural nerves and are prone to serious otitis media-like conditions during the first year of life. 50 to 70% high percentage seen in the first year of life. Routine evaluation in the first year, and even every year is advisable. So audiologic evaluation at least once between 5 to 13 years, and every year is recommended. So coming to the thyroid dysfunction, 13 to 54% have hypothyroidism. Thyroid function tests are recommended once in neonatal period at first contact, and then every year. So in neonatal period, it is a protocol that we should screen every child for hypothyroidism. So you have to screen them, and at every first contact, every time when they come to you, first contact is like when they come for immunization or some well baby clinic, you should get them at least once, and then every year you have to continue the thyroid dysfunction. This should include the anti-thyroid antibodies also, especially in older children if etiology is more likely to be autoimmune. If autoimmune conditions are suspected, then you have to go for anti-thyroid antibodies. Atlanto-occipital subluxation. The incidence is variable, reported in 10 to 30%. Lateral neck radiograph is recommended once between 3 to 5 years before surgery for participation in special games, or earlier if signs and symptoms suggest cord compression. Any symptoms of cord compression are present, or for any games or lateral neck radiograph should be done at least between the age of 3 to 5 years to rule out this Atlanto-occipital subluxation. Coming to the behavioral and psychiatric forms, in general, naturally, spontaneity is less in them. Genuine warmth, cheerfulness, and gentleness, patience, and tolerance are characteristic of Down syndrome. And psychiatric comorbidities occurs in 18 to 38%. These include ADHD, oppositional deficient disorder, autism, OCD, and psychosis. All these should be ruled out. So how do you record a history in a case of Down syndrome? When recording the history from the parents, clinician should include the following. Don't Forget to ask them about the vision and hearing. Down syndrome, the comorbidities may be present. Ask about the developmental delay and take a developmental history by yourself and rule out any respiratory tract infections. Ask a history about feeding to ensure any adequate calorie intake is present or not. Ask them whether they have gone for any prenatal diagnosis and ask for any GI blockages or duodenal atresia or duodenal webs. And vomitings, with how you'll ask them vomitings, you can ask history of vomitings and you can suspect the underlying cause. So absence of stool, the child is passing stools or not, this not only rules out the Hirschsprung disease but also constipation is feature of congenital hypothyroidism also. Why I am stressing about congenital hypothyroidism here is Down syndrome cannot be prevented, but congenital hypothyroidism can be treated. So you have to rule out and delay in any cognitive abilities, motor language development or social competence, presence of any arrhythmias or fainting episodes, palpitations or chest pain secondary to heart lesions might be present. So ask for the history, ask for any symptoms of sleep apnea and ask for symptoms of atlantoaxial instability, like about 13 to 14% of patients are asymptomatic. So 1 to 2% have symptoms that require treatment. How do we ask for the symptoms? It's the symptoms of cord compression. So diagnosis, presence of 8 or more characteristic clinical features leads to definitive diagnosis. Mainly Down syndrome can be diagnosed clinically, and chromosomal analysis is always recommended and of utmost importance in doubtful cases, because we have to at least counsel the patient. If the child is a first sibling, you have to counsel them for the second also. So prenatal diagnosis, how do you diagnose it prenatally? Is the fetal karyotyping by chorionic villus sampling, which is done at 10 to 12 weeks, that is at 3 months, or amniocentesis 16 to 18 weeks, or quadricentesis greater than 18 weeks. So it is in the 3-month CVS, in the 4th month to 5th month, it is amniocentesis, and more than 18 weeks, that is completing a 4th month, that is quadricentesis. Alternatively, if invasive procedures are not advised, then an initial screening with the maternal serum markers, that patients are not taking a invasive technique, then go for the maternal serum markers like PA, A, and B HCG levels in the first trimester, and also serum alpha fetoprotein levels. We can go for HCG levels, unconjugated estriol, and inhibit A in the second trimester. If the risk is greater than 1:250, even fetal karyotyping can be offered, and risk of fetal loss after if you do the procedures, you will have a risk, though at least fetal loss can be seen in after CVS, quadricentesis, and amniocentesis. In CVS, it is 4%, quadricentesis 3%, and amniocentesis is 1%. So fetal ultrasound helps to detect fetuses who are at the risk of chromosomal abnormalities. Important findings in the second trimester are increase in nuchal fold thickness, short femur length and humerus length, and duodenal atresia. In first trimester, nuchal translucency. Look for the NT scan. You will go for a nuchal translucency scan and see whether nasal bone is present or not. Go for a maternal serum screening, that is HCG levels or whichever is recommended, and ultrasound screening techniques, and cannot rule out Down syndrome. Both of them, if we do only serum screening and ultrasound, they strongly cannot rule out, but you have to go for a screening first, and if risk is there, then you have to go for the amniocentesis or quadricentesis. Counseling part, parents of children with Down syndrome should be counseled with tact, compassion, and truthfulness. Inform about the disorder as early as possible after the diagnosis is confirmed. Counsel the parents in privacy and with mother holding the baby comfortably. Simple language and positive language give them hope. Sufficient time for the parents and to ask questions also. Discuss about the problems and associated factors in the problem. Importance of early stimulation, give them importance to early stimulation. Do not talk about adoption or institutionalization unless asked. Both these should be discouraged. Ask the patients to contact local Down syndrome association if it exists. Talk about genetics and chromosomal analysis if the parents are interested. Inform about recurrence of risk and possibilities of prenatal diagnosis if they're planning a second child, and schedule the future appointments. The risk of recurrence: women 35 years of age or less who have a child with trisomy have 1% risk of having another child, but translocations risk is about 10% and 4 to 5% if father is also a carrier. This is the risk. And 21st March is the World's Down Syndrome Day, and let us hope to prevent this Down syndrome by the early diagnostic techniques. Thank you. Please save your chat.